keep going. So here's a 38-year-old male who comes in with shortness of breath. Maybe the LV doesn't look so bad, a little thick. The left atrium, maybe a little dilated. We have a nice little reverberation artifact here. RV looks okay. Maybe the LV's dilated. Let's see, this is a centimeter, so we're close to 5 centimeters or so. We put color on. That looks normal, right? I don't think so. We kind of look at the valve, like what's going on here? A little thickened, but the aortic root is not very dilated. But if we look at this regurgitation, essentially, they attempted to measure vena. It looks like it's filling the entire LV outflow. That's a lot. That is a lot. We also, if we look here, not as classic, but we might see a little bit of diastolic fluttering on this mitral valve by M mode, because what's happening is that regurgitation is just hitting that anterior leaflet. It's restricting it in diastole, making it difficult for it to open. You actually even see it kind of get pushed down a little bit here, right? What did we measure? 5.5 centimeters, no LVH. Maybe the EF, we have to obviously look at other views for our EF. Ascending aorta, a little dilated, 4.2 centimeters. Look at that aortic valve. It looks trileaflet. I don't know if I see anything dancing around there. I didn't say they came in with a fever if we're worried about endocarditis. We put color on here, and you can just see that whole coaptation is just full. This is just this regurgitation bleeding over through. But that is a lot of aortic regurgitation. Here we have our, now that EF doesn't look quite normal, right? Look at all that regurgitation coming in through here. We want to throw some Doppler through there. If we look at our continuous wave, one of the parameters that we look at is a pressure half time, and anything less than 200 would be severe. So the steeper that this pressure half time is, the better. You may want to increase our sweep speed, right? Kind of aim for a lot of measurements to have maybe 2 or 3. And one of the things that we look for differently was if there is significant aortic regurgitation, we look to go in the abdominal aorta, if we can, and just see if there is holodiastolic reversal in the abdominal aorta. You just think about, there is so much AI that it's dumping back into the left ventricle. It's pulling all the way from the abdominal aorta. That's going to be significant. We're not always looking at the aorta. Here it doesn't look like we really see much reversal, but they did catch in the suprasternal notch in the descending aorta, they did catch some flow reversal here. So I'd say definitely, you look at the vena contracted was almost 2 centimeters. Greater than 0.6 is significant, and one of the other things we didn't see measured, but we like to look at the jet width compared to the LVOT, and if that's essentially greater than 65%, so if it's more than 65% of that LVOT is full of AI, that's going to be pretty consistent with severe. And then I'm not going to get into PISA and regurgitant volumes and all those things, but all you have to do is just remember every single one of these little parameters.